pretty amazing when you think about it. Something like developmental dysplasia of the hip, DDH, diagnosed when you're just a baby, could actually, link to needing a hip replacement much later on, maybe even in your 60s.
It really highlights the long-term impact, doesn't it?
Absolutely.
Yeah.
So today on the deep dive, we're really focusing in on DDH. We've got a great set of revision notes here. And our plan is basically to pull out all the crucial bits you need to know for understanding it clearly and hopefully remembering it easily. Everything from the definition right through to complications.
Sounds good. And this is really for anyone wanting a solid overview without getting completely bogged down in, excessive detail.
Exactly. So let's start at the beginning. What exactly is DDH?
Well, fundamentally, DDH means the baby's hip joint hasn't developed quite normally. The notes talk about abnormal development or displacement.
Displacement, so it's moved out of position.
Potentially, yeah. It's a spectrum. It could be really mild, like the socket, the acetabulum is just a bit shallow, but the hip's stable. Or it can be more severe, maybe unstable right from birth, or even properly dislocated, where the ball part of the joint is out of the socket.
And crucially, it's developmental, right? It's not always just there at birth.
That's a key point. It's an ongoing process. It can happen during fetal development or even in early infancy. Its presentation can vary quite a bit.
Which is why those newborn checks are so important. I see Barlow's and Ortolani's tests mentioned here.
Exactly. Those are the hands-on tests doctors use to feel for instability in a newborn's hips, clicks or clunks.
Okay.
And the notes also mention other maybe more subtle signs parents might spot, like uneven skin folds on the thighs or bottom, or maybe one leg looks a bit shorter.
Got it. So maybe a little memory tip.
Yeah.
The D's in DDH developmental, because it evolves, and displacement, because that's what can happen to the joint.
Nice one.
So what actually causes this, do we know?
Often the exact cause isn't known. It's thought to be, well, a mix of things.
A mix, like what?
Likely some genetic predisposition, maybe it runs in families, combined with environmental factors during development.
Okay. And the notes mention some potential contributors. Hormonal, mechanical.
Yeah, things like hormones, the baby's position in the womb, mechanical factors, and that family history connection.
Which leads us straight into risk factors. Looks like there are quite a few.
There are. It helps to group them. A really big one is gender. Girls are about 6 times more likely to have DDH.
6 times. Wow, that's huge. What else?
Breech presentation.
No.
Especially with vaginal delivery. That's a major one.
Okay.
Family history, definitely. If a parent or sibling had it, and maybe surprisingly, being the firstborn child.
Firstborn. Any idea why?
The notes don't specify exactly why, but it's a recognized association. Also, things related to the pregnancy itself, like low amniotic fluid oligohydramnios, and heavier babies, apparently. Birth weight over 5 kilos is listed, plus a specific foot deformity present at birth, congenital calcaneal valgus.
Okay, quite a list. And there are even more factors mentioned here. Sibling history gives a 5% increase.
And the hormone thing is interesting. Maternal relaxin, the hormone that loosens ligaments for birth, might affect girls more, potentially explaining some of that gender difference. It accounts for maybe 80% of cases being female.
Makes sense.
Yeah.
And multiple pregnancies, premature births, even links to neuromuscular disorders like cerebral palsy.
Yes, those are associated as well. And it's worth noting, if DDH is picked up later, say after 3 months, the risk factors might look a bit different.
Oh, like what?
Things like a head-first delivery, which is usually protective, but also a history of tight swaddling where the legs are kept straight and together. That comes up in late presentations sometimes.
Okay, that is a lot to remember. Is there a handy way to summarize these risk factors?
There is. The note suggests thinking of the 6 Bs and an F.
Okay, let's hear it.
So, 6 times more likely in girls. Girls.
Got it.
Breech presentation, birth order first, big baby, over 5 kilograms, low birth fluid, oleohydramnios, and then F for family history, or that foot deformity.
The 6 Bs and an F. That's really helpful.
Yeah.
Okay, so we know what it is, who's at risk. Now, the pathophysiology, what's actually going wrong inside the hip joint?
Yeah, so fundamentally DDH happens because the parts of the hip joint, the socket, the acetabulum, and the ball, the femoral head, don't develop correctly together.
They don't quite match up.
Exactly. That poor fit, that abnormal development leads to the joint being unstable. The ball isn't held securely in the socket.
Yeah, and that instability then causes?
It can cause the femoral head to slip partially out, that's subluxation, or even come completely out, which is dislocation. And obviously that messes with how the hip joint works.
Okay, that makes sense. Now, if a baby shows potential signs, it might not always be DDH, right? What else could it be?
Good point. There are definitely other conditions to consider differential diagnoses.
Yep.
Well, sometimes a newborn's hip just feels a bit loose initially, but it tightens up on its own. That's transient neonatal hip instability. Much more serious would be septic arthritis, an infection in the joint.
Right, that needs urgent attention.
Absolutely. Then there's Legg-Calvé-Perthes disease, but that usually shows up a bit later in childhood. Other hip infections, or even something like muscular torticollis, a neck issue, can sometimes cause asymmetry that might raise concern.
So ruling these out is crucial for getting the diagnosis right.
Definitely.
Let's talk numbers. How common is DDH? What's the epidemiology?
In the UK, the estimate is around 1 to 2 cases per 1,000 live births.
Okay.
It seems to be a bit more common in the left hip, and about 20% of the time, both hips are affected.
And the notes mention some wider stats, too.
Yeah, affecting maybe 1 to 3% of all newborns overall. And that striking statistic, again, it accounts for nearly 30% of primary hip replacements in people under 60.
That really puts the long-term significance into perspective.
Yeah.
Does how we screen for it change the numbers we see?
It can, yes. If you screen everyone with ultrasound, you'll naturally pick up more subtle cases, so the prevalence might look higher compared to systems that rely mainly on clinical exams like Barlow and Ortolani, using ultrasound more selectively.
Right.
And there's a thought about why the left hip is more common, often related to the typical position of the baby in the womb before birth. The left occiput anterior position often puts the left hip against the mother's sacrum.
Fascinating. And the cultural aspect, too. Swaddling versus carrying.
Yeah, that's quite telling. Higher rates in cultures that practice tight swaddling, keeping the legs straight. Lower rates where babies are carried with hips spread apart in that sort of M position.
It really shows that gene-environment interaction.
Yeah.
So, quick scenario. A parent asks, why does DDH seem more common in some places than others? What's the key message?
I'd say it's likely a combination. There might be underlying genetic factors, but environmental things, especially how babies are handled and carried, like tight swaddling versus hip-healthy carrying, seem to play a really significant role in those differences between populations.
Great explanation. Okay, let's shift to the clinical features. How does DDH actually present itself? What do you look for?
In young infants, the main things are often related to that instability, so feeling a click or clunk during the Barlow or Ortolani tests.
Okay.
Also, limited hip abduction difficulty, spreading the baby's legs apart when the hips are flexed. And those asymmetries we mentioned. Leg length difference, uneven skin creases on the thighs or buttocks.
And if it's missed early and the child is older, maybe walking?
Then the signs change. You might see limping or perhaps a waddling kind of gait. The leg length difference might become more obvious.
And these signs are what trigger those screening tests.
Exactly. The Ortolani and Barlow are specifically designed for newborns, and the 6 to 8 week check to detect that instability. The notes reiterate that universal ultrasound screening isn't standard everywhere, but it's definitely used for babies identified as high risk.
Okay, so focusing on an exam under 3 months, what are the key findings again?
Looking for asymmetry skin folds, leg length, hip abduction range. Positive Ortolani or Barlow tests indicating the hip can be dislocated or reduced. And specifically, limited abduction, less than 60 degrees, is a red flag.
And between 3 and 6 months?
That limited asymmetrical abduction is still a key sign. Also, the Galeazzi sign might become positive, where you bend the hips and knees and one knee appears lower than the other, suggesting a shorter thigh bone on one side.
Right, and in older walking children.
Still might see limited abduction when the hip is fully flexed. They might walk on their toes on the affected side or just have a painless limp. If both hips are dislocated, you get that characteristic waddling gait, often with an exaggerated curve in the lower back hyperlordosis. Interestingly, the Galeazzi sign might be absent in bilateral cases.
Makes sense if both sides are affected. So maybe another memory aid for infants, the 4 Ls. Limping, though later, limited abduction, leg length difference, and lines, those asymmetrical skin fold lines.
That works.
So if DDH is suspected, what investigations are next?
Well, the physical exam is paramount, but imaging is crucial to confirm and monitor.
Right.
For infants under about, say, 4.5 months, dynamic ultrasound is the go-to.
Dynamic, so watching it move.
Exactly. You can see the hip structures, assess stability as the hip is moved, and check how well the socket is forming. Very useful in that early stage before the bone is clearly visible on X-ray.
And after that age?
Once the femoral head starts to ossify, turn to bone, usually after 4-6 months, then pelvic X-rays become the main tool. They give a clear picture of the bony alignment.
Okay. Are CT or MRI ever used?
Sometimes, yeah. for more complex cases, maybe planning surgery or if there's uncertainty, but they often need sedation for young kids. There's also arthrography mentioned, injecting dye into the joint, which can help surgeons make decisions during operations.
Got it. So diagnosis confirmed. What's the management plan?
For infants under 6 months, it's usually non-surgical first. The mainstay is the Pavlik harness.
A harness, right. How does that work?
It holds the baby's hips in that optimal flexed and abducted position, encouraging the femoral head to sit properly in the developing acetabulum. It's most effective if started early, ideally before 6 to 8 weeks, and it needs regular checks and adjustments.
And what if the hip is stable, just mildly shallow?
Sometimes observation for up to 6 weeks might be an option with close ultrasound monitoring.
Okay. When does surgery come into play?
If the harness doesn't work, or if the diagnosis is made later, after about 6 months.
What kind of surgery?
A common one is a closed reduction. The surgeon gently maneuvers the hip back into place, often under anesthesia. This might be combined with a small cut to release tight tendons, a tenotomy. For older kids or more severe cases, bigger operations like osteotomies, cutting and reshaping the pelvic bone or femur might be needed.
And outcomes are better with earlier treatment?
Generally, yes. The notes mention outcomes are less favorable the older the child is, and there are higher risks of complications like avascular necrosis, where the blood supply to the femoral head is disrupted, or the hip dislocating again.
And follow-up is key afterwards.
Absolutely essential. You need to follow up until the hip is stable, both clinically and on X-ray. How often and for how long can vary, but it's crucial. And sometimes treating one hip can unmask issues in the other.
Right, so another memory tip for management. P before S, Pavlik harness, usually comes before surgery.
Good one.
So overall, what's the prognosis? How do kids with DDH generally do?
On the whole, it's good, particularly with early diagnosis and the right treatment.
So most can expect normal hip development.
Yeah, appropriate management usually leads to normal hip function, but, the long-term outlook, it does depend on how severe it was initially, any complications, and how well the treatment worked.
Which brings us to complications. What can go wrong if it's untreated or even with treatment?
If left untreated, you're looking at long-term hip instability, deformity, definitely early onset osteoarthritis, and significant functional problems.
And treatment complications.
Even with surgery, things can happen. Redislocation, stiffness, bleeding, and that avascular necrosis we mentioned in the notes say 5–15% risk in some cases.
That's quite significant.
It is. And remember, DDH is a major cause of childhood disability, and as we keep saying, leads to a surprising number of hip replacements later. Even with good treatment, there might be long-term risks like degenerative joint disease or even low back pain.
It really underscores the need for vigilance. Okay, final thought then. Considering all these potential long-term issues, what would you say is the absolute most crucial part of managing DDH?
For me, it has to be early, accurate diagnosis, getting that diagnosis right at the beginning, ideally in those first few weeks or months.
Why is that window so critical?
Because it allows for the use of less invasive treatments like the Pavlik harness during that key period when the hip is still rapidly developing. This gives the best chance for the hip to form normally and hugely reduces the risk of needing complex surgery and facing those long-term complications. Missing that early window just makes everything potentially more difficult down the line.
That makes complete sense. Early and accurate. Okay, so let's just quickly wrap up the key takeaways from our deep dive on DDH. It's clearly a spectrum of conditions, not just one thing. Timely diagnosis and management are absolutely vital.
And early intervention really does lead to the best outcomes.
Yeah, so knowing the risk factors, recognizing those clinical signs we discussed, and using the right investigations, ultrasound early on, X-ray later, are all key steps.
Definitely. And hopefully working through this has helped solidify your understanding.
Absolutely. And for anyone listening who's prepping for their MSRA exams and wants more resources, do check out pastthemsra.com and freemsra.com.
Great resources there.